Welcome everyone to today's webinar. I am Mary Rectoris with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are really looking forward to hearing all your questions. In a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is my pleasure to start today's webinar by introducing our presenters. Mark Shapiro is the Director of Pharmacy for Mont Health. In the first half of his career, Mark Shapiro developed and managed a pharmacist-ran anticoagulation clinic that has grown to over 1,200 monthly visits and $2.5 million in annual revenue. In the second half of his career, he was promoted to Pharmacy Operations Manager at Mont Health. During that time, Mark Shapiro was responsible for regulatory compliance and daily operations. In January 2015, Mark Shapiro was promoted to Director of Pharmacy. Since that time, he has led a successful upgrade of their EHR, implemented a new billing software for 340B, received capital for a complete pharmacy model, and completed 3 successful GTC accreditation surveys, to name a few. He is currently working on a complete revision of clinical pharmacy services, focusing on quality metrics and alignment with provider service lines within the organization. Rob Easton is the Director of Central Pharmacy and Shared Services at Scripps Healthcare in San Diego, California. He was previously the Manager of Pharmacy Operations for Scripps Mercy San Diego campus, the largest teaching hospital of the Scripps Health System. Prior to earning his Doctor of Pharmacy degree from the University of the Pacific, he served 4 years as a Surface Warfare Officer in the United States Navy and worked as a pharmaceutical sales rep for Eli Lilly and Company. Rob is currently the pharmacist in charge of Scripps Central Pharmacy Production Center, a centralized hospital packaging pharmacy. CPCC provides sterile injectable preparations, produces repackaged oral solids and solutions, and administers the environmental sampling program for the 5-hospital system. He also oversees Scripps telepharmacy service and the system resource services for pharmacy, which provides workforce staffing support to the hospital and clinics within the system. Kelly Morrison leads the nation's largest remote pharmacy service business and participated on the initial team that pioneered the remote medication ordering processing service for Cardinal Health at a national level in 2003. That included building and coordinating a multidisciplinary team of professional, regulatory, technical, and legal staff. She also presents to boards of pharmacy to discuss licensure requirements for the remote medication ordering process service in several states and assist boards to draft rules specific to remote order entry. Upon the service launch in 2003, she was responsible for developing the technology infrastructure to support remote pharmacy service centers for healthcare facilities needing 24/7 pharmacy services, and submitted a patent for the proprietary technology that later became commercialized and used by over 450 hospitals today. For the past 14 years, she has worked with the operational, clinical, quality, and technology teams providing remote pharmacy services to over 400 healthcare facilities. Kelly, it is now my pleasure to turn the floor over to you to begin today's webinar.
Thank you, Mary, and good morning, everyone. I'd like to thank you all for joining our webinar today. And during this session, if you'll go ahead and advance to the next slide, Mary, we'll be discussing healthcare's reform on the impact of pharmacy, and then understanding how different remote pharmacy models can be leveraged to address some of the challenges that the healthcare facilities, whether it's acute or non-acute, are facing today. And then finally, learn how 2 health systems have expanded their pharmacy services to execute upon strategic initiatives, what their challenges were, really the evaluation they went through to consider their approach, the approach they actually implemented, and then results. So if you can advance to the next slide, please. As we continue to work through the challenges of healthcare reform, I think we all can agree that doing more with less has become the standard of practice for hospital pharmacists. There's an increased need for pharmacy-led clinical programs to drive hospital cost savings initiatives, reduce readmissions, and increase patient satisfaction, all while personnel and project budgets continue to be flat, despite the growing hospital administration expectations. Next slide. As a result, many hospitals and retail pharmacies as well have leveraged some type of remote pharmacy model in many different ways as an effective and affordable approach to enable them to implement strategic clinical initiatives. As we look at that, several healthcare facilities really are going through an expansion of pharmacy services and have been for the past several years, whether it's implementing medication reconciliation programs, transitions of care initiatives, expanding pharmacy support to the emergency department and other procedural areas that historically pharmacy wasn't as actively involved with, as well as expanding pharmacy support to even ambulatory care facilities that we see today. We're also looking at many new technologies, and they continue to emerge to help drive a lot of these programs. However, despite all the new technologies that enable us to try to execute and implement these, pharmacist labor is still absolutely critical and essential to the success of these programs. So we see many healthcare facilities looking to try to redeploy on-site pharmacists from order entry to really focus on these key strategic projects and clinical initiatives. We see many health systems going through short-term needs, whether they're implementing EHR technologies, converting other software programs within their hospitals or their health system. And a lot of these, again, aren't long-term, but they really have a spike and require a spike in pharmacist labor as these projects are going on. A lot of health systems are also looking for solutions to provide workload balancing and reduce order review and order entry times, especially during peak hours. What once was a 24/7 staff of pharmacists, and it was adequate to provide, effective and efficient order review during order entry to ensure nursing and physician and patient satisfaction. Now when pharmacy is being pulled in many different directions and pulled out of the pharmacy, that clearly leaves a gap and many challenges for pharmacy in ensuring consistent levels of service. In addition, many health systems are also looking to leverage remote pharmacy models to provide nursing and technician supervision, particularly in some of the smaller or rural facilities that lack or have lacked in the past 24-hour pharmacist coverage and clinical review. And most recently, with the many natural disasters that we face throughout the country, many hospitals and retail pharmacies have looked to implement some type of remote pharmacy service to support their business continuity. Next slide, please. I'd now like to turn the presentation over to Mark to share his specific challenges and approach to leveraging a remote pharmacy model.
Good afternoon. I'm Mark Shapiro. I'm the pharmacy director for Mont Health. Most everybody doesn't know where Mont Health is, but we were about 20 miles southwest of Charlotte, North Carolina. We're a 435 licensed bed hospital. We have 43 physician practices, a hospice house, a long-term care facility. The pharmacy department specifically, we have 64.5 FTEs, 6 residents, and you heard earlier with the introduction that we are a DISH hospital or have a very extensive 340B program. Next slide. Our biggest challenge was how do we provide more direct patient care services with the same pharmacist group that we had. So one of the things that we wanted to do, and one of the things that we did do, is we converted it to Epic back in August of 2015. So we started at that point in time looking for telepharmacy to come in and kind of help us with that transition, and then also to provide some additional coverage for us. Unfortunately, North Carolina at the time did not allow for a 24/7 hospital to actually have or use telepharmacy. So we actually petitioned the state board at that time to see if they would allow for a 24/7 hospital to have telepharmacy. North Carolina actually passed that back in September of 2016. Next slide, please. So our options when we got past the Epic implementation and got into really trying to look at what we're going to do from expanding patient care services, we looked at potentially increasing our internal FTE counts. The problem with that is, for us to actually increase an internal FTE count, it wasn't just a single person or a single body. It really was going to be another 7-day coverage. So we're looking at like 1.5 FTE. So as most everybody who's on the call understands, is FTEs are a little bit of a challenge today in healthcare with the change in healthcare reimbursement rates and everything else that's happening. So that was one option we had. We also looked at completely just changing our staffing model for our pharmacists and what that did. at the time, there was a little concern with staff satisfaction and were they willing and able to make that move. We have since actually made that change, and I'll discuss that a little bit in just a few minutes. Another one of those was kind of making a different little combination of pharmacist roles and redistributing some of their activities. So taking some of the order entry verification off our decentralized pharmacists already. And then the last one we had was basically do nothing, but we knew that we needed to provide some better patient care. Next slide, please. So what we decided to do is we decided to partner with a remote pharmacy service. That remote pharmacy service allowed us to then redistribute some workload across all of our shifts. So we were able to move some workload, some internal workload into our second and third shift staffing model. It also allowed us to redistribute our decentralized pharmacists' clinical activity to allow them to have more patient interaction. One of the main things that we focused on was providing discharge review of patient medications. Next slide, please. So some of the results that we have, as you can see here, the first 3 months, we had 277 clinical interventions on discharges. There was 1,178 total medications that were actually reviewed. Month 4, we had 147 clinical interventions at discharge, and that was 542 discharge medication reviews. Currently, in the month of October, we have 797 total patients that were reviewed. We had 149 interventions, and it was 218 counseled, sorry. New numbers that were just given to me. Next slide, please. So some of the things that we didn't expect at the time of looking into telepharmacy is some of the unintended consequences and some of the unintended benefits that we actually were able to get from our staff. On average, our staff processed right around about 20 to 22 medication orders or interventions per hour. What we noticed with the addition of telepharmacy, that actual number went up to 32 medication orders per hour. So the pharmacists within our own organization actually took it upon themselves to get more engaged, to provide more to coverage and to really help process some of the turnaround time a little bit. As you can see, another benefit that we had with the telepharmacy is that our turnaround time has actually went down. We've decreased our overall turnaround time by about 2 minutes per order, which when you talk about we're processing somewhere between about 5,500 to 6,000 orders a day. That's a substantial amount of time savings to ensure that patients are there. So I guess now I'd like to turn it over to Rob.
Thanks, Mark. My name is Rob Easton. I'm the Director of Pharmacy for Scripps Health Central Pharmacy and Shared Services. On the next slide, a little bit about Scripps Health. So we're 4 hospitals on 5 separate campuses in San Diego, California. We have a network of about 40 clinics with some infusion centers throughout San Diego County. Over 15,000 employees and 2,600 medical staff make up Scripps Health. On the pharmacy side, we have obviously the inpatient hospital pharmacies associated with each of those campuses, and we are expanding our retail pharmacy services and currently have 3 retail pharmacies just adjacent to the hospital campuses at 3 of the locations. Our shared pharmacy services, which I oversee, involve a centralized hospital packaging pharmacy that provides medications, injectable medications for the 5 hospitals. We have our telepharmacy service. And so the telepharmacy service is a group of clinical pharmacists, not physically located in any of the hospitals, but in a distinct location from the hospitals, where they're doing remote order entry and verification. And I say that hybrid because we are currently transitioning to a new electronic health record, and that'll become pretty pertinent as we go through this presentation. Over the next few slides, I'll be talking about 3 separate instances where we've leveraged some remote pharmacy services to help us in achieving the results we need in certain projects, and also talk about the institution, bringing insourcing and starting our own telepharmacy service that's now been in place for just about 4 years. On the next slide, The first instance of leveraging and partnering with a remote pharmacy service came a few years ago, when we needed assistance in meeting the stage 2 meaningful use medication reconciliation requirements. And we knew that we had a fixed time period that we needed to achieve this. But of course, as Mark's alluded to as well, some of the options, including increasing the number of pharmacists, FTEs, or full-time equivalents, was not going to be the most viable option that we would want to pursue for a short-term solution. What we ended up with was partnering with a remote pharmacy service, and that remote pharmacy service was going to supplement our existing staff. They would be able to get into the electronic health record and support the entry, very specifically, of the discharge orders to meet this meaningful use deadline. The importance of this was it didn't impact the clinical services at our different hospital locations, because this was an additional staff that was doing a very specific task to achieve a very specific project end. The results were very favorable for us. You can see we saved over $400,000 in labor. In about 5 months, over almost 100,000 orders were processed in that time period. And the nicest thing, of course, was that it left all of our clinical services, the pharmacy service that we provided, were left intact, so we could continue to provide patient care. Next slide, please. So not just based on the success we had with the partnership of the remote telepharmacy service, based on looking at pharmacy leadership, looking at the entire Scripps Health system, there was, and some previous experience with telepharmacy, there was definitely a push to insource and create our own telepharmacy remote order entry service. We wanted to leverage our clinical pharmacist resources across the system, and so we can manage those peaks and valleys. Obviously, seeing the high volumes of a high order volume in the middle of the day, and then that tapering off in the overnight hours. One of the key things we wanted to do was reduce the distributive burden on those clinical pharmacists practicing at the sites. We wanted to free them up from their order entry and not have them so tied to an order queue, so that they could get closer to the bedside and be there as part of the patient care team. The goal was to be able to support all 5 of the Scripps hospitals, and with this central group, and again, be able to work seamlessly, have our telepharmacists be able to move from covering one hospital to another, but be completely able to work across the 5 hospitals, and in addition, provide after-hour support for the anticoagulation. Next slide, please. So our approach, this is a theme that will often come up. We wanted to have a labor budget neutral approach. So what we did was we moved pharmacist positions, and in some cases, the pharmacists themselves who wanted to make this move, from the hospitals to our remote order entry location. Our staffing and hours operation was really based upon collecting data on when we saw the order volumes go up, and also when we wanted the times that we were looking to free up our clinical pharmacists to participate in patient rounds and other clinical responsibilities. Telepharmacy was to own the order entry and verification process. And what this really meant is that we wanted our remote telepharmacists, when they touched an order, that they would be able to take care of it, from opening it to placing the order to having it completely taken care of. And so what this meant was, at least early on, really focusing where we would have our telepharmacists be active, primarily the med-surg floors, and not so much in the neonatal ICUs or in the OR spaces, where we would still rely upon the site pharmacists to not only do order entry, but also interact with the clinicians at the sites. Again, the telepharmacy was to process more orders, allowing our clinical pharmacists to become more active in clinical rounding, to become more active in patient counseling, particularly discharge medication counseling, and then also to allow them to participate and increase the presence and influence of pharmacy through the different clinical committees, whether it's infection control, antimicrobial stewardship, and the like. Next slide, please. So the results and benefits that we've seen over the course of instituting our own telepharmacy service was we've been able to take on about half of the orders done system-wide. And that's been a great thing to do, and something that our site pharmacists have really become reliant upon to allow them to do their clinical responsibilities, to free them from being tied to the queue. Some of the other benefits that we've seen, which I think we could have predicted, but it wasn't necessarily part of the initial calculus, was we've had a lot of standardization of pharmacy protocols, because although we were all the hospitals were of the Scripps Health system, they were 5 distinct hospitals, and so there were many differences in practice across. And what we've been able is to standardize. We've been able to standardize the way we're dispensing medications, standardize the way they're administering, and I really believe that this has enhanced patient safety, because for our telepharmacists that are putting in the orders, or whether there's nurses or pharmacists that are floating between the different hospitals, they're seeing the same process in every location. Next slide, please. And in this final instance is one that's currently ongoing now. So this is a real-time view of Scripps Health as we transition to a new electronic health record. So we're a little bit behind Mark and Caramount, but we should have this transition done by 2018. But really, it was to get 5 Scripps hospitals, the Scripps clinics, our ambulatory surgical centers, our infusion centers, transition to the new electronic health record. And the initial plan was to do it over a year. Pretty aggressive plan, which has already been pushed out to look more like 18 months. But we would do it in waves. We would have 1 hospital, all the clinics go live first, followed by 2 hospitals each with the second and third wave. And not to want to make it any easier on ourselves, the IV workflow software that we have in the inpatient spaces, we're introducing that to the clinic spaces. So that's just been another interesting aspect that has actually involved some of our telepharmacists in helping with that transition. On the next slide, some of the considerations that we had on how we would make this transition to the new electronic health record. We knew that we would need additional pharmacists in some form or fashion. This was based upon discussions that we had with those from Epic and their suggestions, but also lots of discussions with other health systems who had gone through a similar transition. We knew that we would need to be able to backfill the pharmacists who are attending training. We knew that we would need to be freeing up our specialty pharmacists, and there would be even some subject matter experts that would sort of evolve out of the training they were getting, and we want to be able to get them off the order entry queue. And we also wanted to be able to have additional support at the initial go live and then for that first month at the different sites. The input that we received led us to decide that we were going to need an additional 5 to 7 pharmacist FTEs. And so really we considered only 2 different options. One was that we would hire 5 more clinical pharmacists full-time with intent to stay on after the go live and with the final hospital. And the other was to outsource, to partner with a remote pharmacy service that would support hospital sites, particularly around order entry, and allow our existing Scripps pharmacists to fill the roles that will need them as we move through this implementation process. Next slide. So we opted with option number 2. We calculated how many orders that we thought a pharmacist should be able to enter. And we really settled around the number of about 50 orders an hour. That led to a decision of 7 contracted FTEs to support this transition. The times of day and which days of the week were we on, we really settled on Monday through Friday, because when you look at when training would be, when the projects would be going on, that would really be a weekday sort of process. It would only be Monday through Friday. So that's where we would ask that our partner to provide that additional remote pharmacy support. And the time frame we used allowed support from a couple different remote locations in different time zones. I'm not going too deep into tonight and getting started at a reasonable time in the morning. And then the last decision was, what role will they play, and where will they be doing the order entry, and will they the remote pharmacy service be doing both the new coming online new EHR as well as the legacy system. And our decision was really to just support 3 of the 5 hospitals, the 2 largest, and then one of the Mercy hospitals, which is a sister hospital. And that's where we would focus this remote telepharmacy support. So these also happen to be 3 of the last locations that would be going live. And so that our remote telepharmacy service that we were partnering with was going to go ahead and can only work on the legacy system and not be working on the new system. On the next slide, a little bit just about how we implemented and the results that we've seen. So there was some it was important to have initial site visits with a partner at our telepharmacy to go over our standard operating procedures and our policies and understand the processes. We did a lot of training in person when we could and remotely via Skype when it was necessary for those who are practicing out in a different location than us. And for the first 3 months in particular, it was good to have weekly and monthly meetings, not just with the pharmacists doing the work, but also with leadership, so we all understood what we were trying to achieve and how we were coming to those terms. What's been great to see is throughout this project is that we've been able to maintain the same order entry support level across the system. They're getting close to 50%, and that's been important for the sites because that's what they've come to expect, and we didn't want to see that tail off at all. Really what we've seen is that we were able to achieve those things that we had aimed for at the beginning, which was outsourcing these by outsourcing the services, we were able to free up our clinical pharmacists to support the build, support the go live, and really help us across the implementation. We've been really happy with the way things have gone on so far, very, very satisfied with the results achieved, and very happy overall with the implementation process. And with that, I'd like to turn it back over to Kelly.
Thank you, Rob, and thank you, Mark, as well, for walking us through just some of your challenges and approaches to leveraging remote pharmacy services really as an enabler to help address them. Next slide, please. So really, just to kind of sum up some of the benefits to leveraging remote models, and you heard some very specific benefits that both Mark and Rob went through, is that we can really categorize them through operational, financial, and even cultural, which sometimes are a bit unexpected. And talking to health systems, this is some of the feedback that they provided us. But as it relates to operational, clearly, leveraging a remote model can enable the on-site pharmacy's full commitment without distractions when they're engaging in training or implementation of a new system or any new initiative they may be going through. And again, what's important to note is remember that, especially for projects specifically that may be short-term in nature, thinking about leveraging a remote model might make a lot of sense because that remote model can actually help your on-site team scale up and scale down as needed, because you can look at bringing them in just for short-term and not necessarily as a long-term solution. From an operational perspective, you can also ensure that pharmacy service levels are consistent when the pharmacists are pulled away temporarily or redeployed to clinical initiatives. I know both in Mark and Rob talked about, in Mark's case, turnaround time actually improved with the supplementation of the remote pharmacist helping that on-site team. And through Rob's challenges and study, we looked at that really it was important not only for turnaround time to be done for the clinical interventions, just a consistent level of service, but also maintain that order volume, close to 50%, that the internal telepharmacy services had been providing already. As we think about financial benefits, clearly leveraging a remote model externally can help eliminate costs associated with recruiting, training, benefits, etc., and can also help reduce preventable adverse drug events and costs associated with the mitigation. And really what that's around is that ensuring that timely prospective clinical pharmacist review of all orders prior to administration. And if your pharmacy staff is already being stretched thin or pulled away from pharmacy, leveraging remote pharmacists to make sure that they're constantly looking at your order queues, constantly verifying the patient's medications, working with nurses and the providers if there are suspected preventable adverse drug events or other interventions that need to be done. It's really important, as we all know, to ensure those continue to be done. From a cultural perspective, this one's a little interesting because one of the things, that we look at, of course, we can enable the pharmacy staff to scale without impacting FTE personnel. And in many health systems that I've spoken with, and you heard from Mark and Rob, in some cases they may need 7 or more full-time employees or the equivalent to help with projects, to help not only in the preparation for the projects, but cut over day for projects, etc. And being able to not impact your FTE count on site, not hiring up to handle a 6-month, 12-month, or 18-month project only to then have to decrease staff. The on-site staff really, I think, appreciated the fact that all of their teams weren't impacted when there was a need to scale up or scale down. And finally, really is leadership's commitment to showing the importance of work-life balance and job satisfaction. As we talked about in the very beginning, and some of the effects and impacts of healthcare reform, everyone's expected to do more with less. We're all expected to pull costs out of the system. But to do that, we certainly don't want to sacrifice the satisfaction of our clinical pharmacists. And so being able to look at alternative labor solutions that really ensure your on-site pharmacist gets to continue to practice at the top of their license and continue to appreciate work-life balance is actually, critical and essential, as I know we all can appreciate. Next slide, please. So really, as we think about the role that remote pharmacy services can play in assisting, pharmacies and hospitals with a lot of their expanded responsibilities is, number one, we can expand the pharmacist's reach and transitions of care. You heard Mark talk about their discharge counseling program and how important that was to free up clinical pharmacists to be able to do discharge counseling throughout the hospital prior to administration in order to really try to impact their 30-day readmission rate. You also heard about supporting the improvement of clinical outcomes, and again, getting those pharmacists out on the floor, working directly with the prescribers, directly with the caregivers, and even the patients. The pharmacist, as we see, is now becoming an integral role on the care teams out of the floors. And when you get them out on the floors, again, that can leave a gap in central pharmacy of who's going to continue to prospectively review the patient's orders while, again, a lot of those clinical pharmacists have been transitioned out or reallocated to other responsibilities. It can increase pharmacy and hospital access to patients. Once again, anything you can do to free up those on-site pharmacists, if you're already a 24/7 operation, free them up to actually working directly with the patients. Everyone's found is incredibly beneficial, has a direct impact on HCAHPS scores as well. And then for some of you that may have affiliated very rural facilities, again, whether they're acute or even retail that may be in underserved communities, leveraging a remote pharmacy model is often a very practical and, again, going back to affordable way to expand pharmacy's reach into some of these underserved communities, working directly with patients, again, that historically we weren't able to execute upon that. And finally, again, remote pharmacy models can really help reduce healthcare costs and increase efficiencies. And I think both Mark and Rob's challenges and their approaches and their specific situations highlighted just that. And again, they had different alternatives that they could have gone with, as they highlighted, whether it was looking at hiring additional full-time employees for short-term, for long-term, or looking to leverage a remote model. And we know that every situation has to be evaluated independently. In some cases, it may be best to go ahead and look at hiring the additional staff. And in other cases, it may be best to pull in a remote pharmacy provider to help. And again, as you heard Mark and Rob both talk about, through their journey and how they were going to address their challenges, they walked through all those alternatives, and each of their specific cases found that for what they needed, and especially at the time, both short-term and long-term, the best solution for them was to move forward in leveraging a remote team to help their on-site teams. If we could go to the next slide, please. So as we wrap up, before we go to questions, just looking to the future, it's very hard to ignore the focus on telehealth. It's growing rapidly. And in the last 2 to 3 years, more and more technologies have evolved to enable telehealth. The price points for some of the technologies continue to go down to make it more practical for healthcare facilities to implement. And, historically, when we looked at telehealth and where telehealth was implemented, it was oftentimes in the very rural or underserved communities. And to ensure that they had access to healthcare services just like the urban areas did. However, now, as we look to how we can actually, what's going on even in the large academic institutions and acute care facilities across the United States, telehealth is a focus everywhere. Telehealth can be leveraged as a way to look at ensuring the clinical levels are exactly what they were before, if not improved, while maintaining and in some cases even reducing cost. Pulling cost out of the system, as we continue to talk about, is going to be key. We're already seeing it, and it's going to be key as we continue to move forward. Also, we're looking at more, effective deployments of telehealth technologies, and they continue to enhance the ability to better meet healthcare needs. And I really want to reiterate, a lot of our focus has been in the acute care and the hospital space. However, more and more often now we're looking at leveraging telehealth technologies and remote pharmacy services to help our ambulatory care environment as well. And at the end of the day, I know we all really want to promote patient-centered healthcare. And so it's pulling teams together, expertise and resources from anywhere that you can, and trying to create a solution that supports, again, and promotes a patient-centered healthcare environment. So with that, I'd like to turn it back over to Mary, and we'd love to be able to answer questions.
Thank you very much, Kelly, Rob, and Mark, for that fantastic presentation. We're now going to begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So Rob, if you'd get us started here today, this attendee is wondering, for centralized packaging, does your state board of pharmacy require special licensure or manufacturer license?
Yeah, so in the state of California, we're currently, and there's FDA guidance out there, and without getting too far into that, we are viewed as a 503A, so a compounding pharmacy, and it does require a special licensure, a CHP, or Centralized Hospital Packaging Pharmacy license. That's in addition to our sterile compounding license, and we actually also have a hospital pharmacy license. So it's not considered manufacturing. It is regulated by the State Board of Pharmacy and the special licensure.
Great, Rob. Thank you for clarifying that. And if you could tackle this one as well. So did you see a reduction in clinical quality of pharmaceutical care when non-clinical pharmacists were performing order entry, verification, and or loss of meaningful intervention at the time of ordering?
So that's a really interesting question. So I think the short answer would be no. There's certain things that our clinical pharmacists cannot be able to do at the site, that face-to-face interaction with the physician. But they are assessing, clinically assessing each patient as they encode orders. And there is a lot of communication with the site. So when there are things that do need to be addressed of a clinical nature with the provider at the site, that there's a pretty seamless handoff that happens electronically that go to ensure that those needs can be met, patient needs can be met by the site pharmacist. What I would say about our telepharmacists, when we've been hiring and what we've seen when we brought people in, all of our pharmacists have inpatient experience, and that's not really been a requirement. Also, as board certification has not been a requirement, but when we do bring in new candidates, those are clearly those with the clinical experience, often several years. Being board certified, we've seen that's been able to transition, and it's in many ways, it's like working out of a main pharmacy in the hospital itself, because there's still the telephonic conversations going on. I hope that answers that question.
Great, thank you very much. And Mark, if you could take this one, how are you addressing medication safety and the risk of adverse drug events, readmissions, and hospitalizations?
Well, that's a great question. That's probably more around about a 30-minute conversation. So our pharmacists that are actually decentralized are doing a lot of those things from a discharge standpoint. We know that our discharge rates have actually improved, or readmission rates have actually improved. We can't really define exactly to the point that the pharmacist impact has had on it, because it's a collaborative agreement with everybody that's there. So nursing, case managers, physicians, pharmacists, everybody has part of that readmission, part of that adverse drug process. We have definitely caught hundreds of potential adverse drug events that they've been able to really catch before it ever reached the patient at that point in time. And I think, utilizing telepharmacy to free up our guys to be in the order verification queue, but still having the processes and still understanding exactly how order verification goes and having access to our electronic medical record, provided them the ability to be able to do that. And we use a lot of different medication compliance tools and definitely some education for nursing, physicians, and for patients at the same time. So.
Great. Thank you very much, Mark. That really clarified that point. So, Rob, this question is geared towards you. So for Scripps, how difficult is it to hire a clinically oriented pharmacist into a remote entry location? And do you find that the remote entry pharmacists also work in the hospital setting? So a two-parter there.
Yeah, so as far as hiring it, and I reflect back on our team as currently constituted, maybe part of it is the newness of it, although it is 4 years old, but our telepharmacists, actually most of them were inpatient Scripps clinical pharmacists prior to coming to telepharmacy. And oftentimes, as with many positions, it's, personal needs, family needs, balancing work-life balance. It looks to some different alternatives. So, and then actually in a couple cases, some of our more recent hires have been pharmacists that were hired into our internal float pool that worked at many of the different hospitals and gained experience, and then at a later time hired into the telepharmacy service. What I would say is when we are posting positions, the clinical pharmacist position that's posted at a hospital or posted at telepharmacy reads very similarly as far as the requirements and what we're looking for. We obviously, there's the distinction, and we do put out that, this is, remote order entry, but it's otherwise, we are really looking for the same type of clinical pharmacist. And just as on top of that, many of our telepharmacists, as they become comfortable with the different sites, they actually will pick up shifts at the hospitals. And I think, while that's not been encouraged or been anywhere part of the process, it has been kind of nice to have that interaction. And what I'm seeing, or what I think I'm seeing, is that these clinical pharmacists who really do enjoy being in the inpatient space and want to keep that, be able to sharpen the sword, so to speak, in that regard. And I went on so long, I forgot the second part of that question. Could you repeat that?
Sure. Let me just scroll up a little bit here. 1 second.
If I can.
So do you find that remote order entry pharmacists also work in the hospital setting?
Oh, yeah. Well, I guess I kind of stumbled right in. So, yes, from previous work, they've been in the hospital. Again, I don't think, actually, we've hired one pharmacist who actually had spent a small amount of time in the inpatient and had spent some time in the IT setting. And so, but interviewed very well. But there was some concern about having valid inpatient experience, and he turned out to be actually one of our best, and has since promoted into a leadership position. But I would say, I won't say 100%, but the majority of our pharmacists are residency trained, have inpatient experience, and really like the inpatient space, and they're at a time in life where they're just looking for something different. But we do have opportunities to get them back in the hospital to meet their individual needs.
Great, thank you very much. And Kelly, if you could weigh in on this one, how did the remote pharmacist enable a dose to be dispensed or a repeat product from their respective pharmacies?
Oh, sure. So technology is definitely leveraged because the remote pharmacist can't be there to physically dispense it. And so in the acute care environment, what typically happens is the remote pharmacist is directly accessing the pharmacy information system, doing the patient reviews, clinical reviews, and processing the orders. There's typically an interface between the pharmacy information system and automated dispensing cabinets out on the nursing floors, so that when a pharmacist has actually approved an order, it will be available for the nurse to dispense out on the floors. There's various security controls around automation and whether or not a nurse can dispense prior to a pharmacist clinically reviewing it, but typically automation is involved and interface to the pharmacy information system. Now, this being said, there are some, and we see some smaller hospitals that don't have automated dispensing cabinets on the nursing floors, or they're not profile driven, meaning they're not interfaced to the pharmacy information system. And in those scenarios, it is critical for the remote pharmacy team and nursing to have a direct line of communication, whether it's through technology or verbally via phone, so that the nurse is alerted when the medication has been reviewed and is approved. It's typically better handled through technology, through different order management systems that exist today.
Great, thank you very much, Kelly. And this one's geared towards you as well. How does the pharmacist licensure work across state lines?
That's a great question, and it varies state by state, and it continues to change. And so the majority of the states today, and this has evolved over time since we began doing this back in 2003, the majority of the states allow remote order entry outside of their home state. There's only a couple today that require you to be within the state. Georgia is one of those, and Michigan is another, for example. All the others allow you to do it across state lines, and they have various requirements then dictating what kind of licensure the pharmacists need. In some cases, only a PIC license is involved for the pharmacy team, and in other states, every pharmacist that's processing orders for patients in their state, they must have a license within that state. And then there's site licensure requirements as well, and again, those vary state by state. Many of the states will grant an out-of-state non-resident site license to the remote pharmacy provider. So as you look to do this, it's really important to check with your specific Board of Pharmacy guidelines per state. And also, we've got a database that tracks those as well, and I'm happy to be a resource for anyone if they had any questions.
Fantastic. Thank you very much, Kelly. And Rob, if you could weigh in here. So at Scripps, do the pharmacists remote verify at home, or do they report at a central location?
Oh yeah, great question actually. So when we started, everyone, it's a distinct location, essentially an office building that they all come into, and the setup, we have sort of a bullpen which has about, I can't remember, maybe 12 workstations. And then we have some office workstations or cubicle workstations beyond that. Now we did test really just to see how it would work, have someone working from home. So we've only really tested the idea. Well, I take that back. We tested it, it worked, and we did have someone, one pharmacist who was working from home. Obviously, you're watching the metrics very closely. It was only one person. It was a pilot program. It actually worked very well. Met all the metrics that we wanted as far as orders per hour and maintaining medication errors at the level of trying to keep that as low as possible. For us, it's kind of a big technology lift to get that set up at someone's house, but it is possible. We've since put it on hold largely as we've gone to, as we're going through this EHR transition. So, we really didn't feel like we had the resources to continue to support that. The other interesting aspect actually was, and this may be very unique to the one person who did it, his comments were like, yeah, it's okay, but I actually prefer to come in at least, most days of the week. So we found it very successful to have everyone coming into a central location to work from.
Great, thank you very much, Rob. And this question is for you as well. Do you triage which orders the centralized pharmacists verify first and orders they do not verify due to safety reasons? And what are your downtime procedures?
Yeah, that's great. Actually, I wish I had the manager who works for me who oversees it could speak at length around this. So we actually do have a standard operating procedure that and we worked with this through a rapid improvement event. We work with the clinical managers and site pharmacists as well to decide, which are the orders that we go to first, which are the priorities, which are the queues. So, neonatal, ICU, OR, we don't touch those. When there is an order that can't be taken to completion, what is the process? Certain medications as well. So it's all stratified in I don't want to say overly lengthy SOP that defines it. Now, as far as downtime procedures. So if it's a real, and we've had this happen where it's a hard, I guess it's the degree of the downtime and what we're able to see. But in its most extreme case, if we have a downtime where we're unable to log in, if it's short, if it's 30 minutes to an hour, we don't really change. But if it's something and we know that it's going to be the day or several days, we actually redeploy our telepharmacists to the hospitals. And they don't have pardon me. Well, Great. They don't have and so we'll deploy them and they'll work from the hospital pharmacy.
Great, thank you very much. And Mark, if you could weigh in here, what percentage of 30-day readmissions are pharmacy related?
Again, just because of the way that our practice is set up, we don't have a direct correlation to what that number is. We know that our readmissions have went down. I have my clinical manager here, so let me see do you have any idea of what percentage that is?
So for any age, any payer, our readmission rate has gone down by about 5% for our big disease states. So that would be like heart failure, COPD. And again, there's so much work going on in those disease states, it's very difficult to determine exactly which portion of the education, outreach, et cetera, has led to that decrease, but we have seen an overall decrease.
Bring the expert in.
Great. Thank you very much, Mark. And Kelly, if you could answer this one, do the remote pharmacists have to be on the list of employed pharmacists for each pharmacy license location?
So great question. The remote pharmacist, each hospital location or retail pharmacy location should have a copy of all remote pharmacist licensure so that if there's ever an inspection or survey, they can provide that. The remote pharmacists are not considered employees of the hospital, and those contracts are typically stated pretty specifically to avoid any co-employment type issues, but the licensure requirements and competency requirements of those pharmacists, that information should be kept and accessible to the hospital at all times.
Great, thank you, Kelly. And a panelist said, it sounds like you focus remote order verification to certain patient populations. Can you dive into a little bit more detail as to the type of medication orders they are verifying?
Sure, absolutely. And in fact, we don't target just specific patient populations. And in looking at most of the remote pharmacy models that are out there today, they're geared toward helping house-wide. Now, there are certain, including ICUs, now there are certain critical areas such as different levels of NICUs and or particular oncology areas or infusion centers that typically are better handled by the on-site pharmacy team. But outside of some of those highly critical care areas, the remote pharmacists typically handle all areas across the hospital. And one of the things that's really key and very important when evaluating a remote pharmacy model is to ensure that those remote pharmacists are completely aligned with your specific policies and procedures around med management and dosing. And if they're armed with that and we can ensure that they're entering orders just as your on-site pharmacists were, there truly shouldn't be a difference.
Great, Kelly, thank you so much for clarifying that. And Mark, if you could weigh in on your experience, what have you seen work best in leveraging remote pharmacy services to support technology implementation?
So around our technology implementation, because of the law back in 2015, we did not have the ability to be able to leverage remote pharmacy verification at that time. North Carolina Board of Pharmacy didn't allow for a hospital which was staffed by pharmacists 24 hours a day, 7 days a week to be able to use a remote order verification. So we really didn't have that at the time of the implementation. Now, what we have seen is we've been through 2 upgrades since then. And so what it's allowed us to do is allowed us to have an additional pharmacist here that's not responsible for the orders to be verified to help with some of the education around the upgrades. So it's kind of served as of having that additional person to verify those orders, but allow somebody else to physically be here to help with the education, answer any questions around any of the new upgrades that went on.
Great, that's a great point, Mark. Thank you very much. Another attendee is wondering, how are remote pharmacy models used in medication reconciliation programs? And Rob, if you want to take that one.
So really, for our telepharmacists, it's really just been an extension of the process that's happening at the sites. When we're talking, and we're in this hybrid model right now where we have Epic and the functionalities around medication reconciliation being managed there, and our older system, which is Centricity, which 4 of the 5 hospitals are on. And so what we're seeing is they're handling as they would at the sites as far as what patients are coming on, the system-wide policies as far as how long before it's the reconciliation is done upon admission, and then what's done upon discharge as well.
Great, thank you very much. And Kelly, if you could just kind of repeat this question here, can you please say the requirements for Michigan licensure and just delve into the specifics there?
Oh, absolutely. So Michigan requires any pharmacist processing orders for patients in Michigan to be physically located within the state of Michigan. And each pharmacist, of course, must have a Michigan license and be working under a licensed pharmacy that also has a Michigan site license.
Great, thank you very much. And Kelly, someone else is wondering, what is the most important consideration to a health system when evaluating using a remote service model?
I think some of the most important considerations, number one, is that you partner with a remote provider that's got not only the technology to enable the success, but also the experience. And so, again, it goes back to it's critical that the hospital ensure that the remote provider is completely aligned with all the hospital's policies and procedures, again, to ensure the pharmacist are any orders just as they would. I think it's also critical to really look at the qualifications of the pharmacist, how many years hospital experience they've had specifically, because if you haven't had very many years of hospital experience, it can make the action of doing something remotely a little more complex and complicated. And the other consideration that I would mention that's incredibly important is that you want to ensure the remote pharmacists truly are doing things through the clinical review just as your on-site team would, that they're proactively looking at the interventions, reaching out to the physicians, reaching out to nurses to get any clarifications or additional information that's required. You don't want to leverage a remote pharmacy provider that's simply just transcribing or doing order entry and not really a deep dive into that patient's entire profile.
Great, thank you, Kelly, so much. And it seems like we have time for just one more question here. So Rob and Mark, if you could both weigh in, are there concerns from large health systems and academic hospitals regarding the clinical experience of remote pharmacists?
Rob, you want to take that or you want me to go first?
I'll go ahead, sure. So I think our experience at Scripps, so we have one hospital in particular with a medical residency program and a pharmacy residency program, and then another hospital, we have another hospital as a pharmacy residency program. And so I think this is an ongoing discussion as far as, and it really started out by limiting the locations and where the remote order entry was going to happen against on the med surg floors. What we've seen over time as the telepharmacists have shown the value added and the clinical ability, that we're creeping into more and more spaces. And as I said, as we move into Epic, what we're seeing is that because our current health electronic health record, the pharmacists can't see all the charting and things like that, and so there's certain things they're not able to do. But as we move to Epic, and they're able to see more, we're seeing as our telepharmacy services move into spaces that they weren't originally. And I think that the important thing has been the discussions we've had with the clinical managers and pharmacy clinical managers and pharmacy clinical directors, as well as them talking not only with the residency programs, but in P&T, so everyone understands what the remote telepharmacy service is.
Yeah, and I'd basically echo the same thing. What we've noticed is that we are on Epic, and we've had Epic since we implemented telepharmacy. So having the access and having the ability to be able to see the patient's full clinical chart remotely, I think has really allowed the telepharmacy folks to be part of that clinical decision and use their clinical expertise to make decisions around what our protocols allow us to do. And we've kind of expanded it to, we do have some of the orders, NICU and oncology orders, that are basically taken care of on site, and that's just because of the complexity of them. But from overall, the telepharmacy has been able to use their clinical judgment based on our protocols to be able to take care of patients directly.
Great, thank you both so much. And that is all the time we have for today. I really want to thank Rob, Kelly, and Mark for their excellent presentations, and to our audience for participating today. Enjoy the remainder of your day, and we really look forward to having you join us for future webinars.